welcome to the first RSA Radiology Spectrum series with AstraZeneca and MCO. Today we are celebrating the motivation of many authorities in UAE to develop a lung cancer screening program. The title of our webinar is Be Lung Aware, Lung Cancer Screening in the UAE. As you can notice, in the program we have 5 remarkable speakers working in different hospitals in the UAE. Oncologists, experienced radiologists in lung cancer screening, AI scientists, and radiologists who implemented AI in their practice for screening. We value your participation in the webinar. Please feel free to share your questions directly into the chat box. The speakers might answer this question after their presentation, or we will leave it later on for the panel discussion. Without further ado, I would like to present our first speaker, Dr. Saeed Rafi. Dr. Saeed is consultant oncologist in the Medclinic City Hospital, Dubai. He is a UK trained and board certified consultant medical oncologist with over 20 years of experience in medicine and cancer medicine. He has extensive expertise in clinical trials and has been chief, principal, or co-investigator on over 100 early and late phase oncology clinical trials. Dr. Rafi also holds a PhD and a postdoctoral fellowship in molecular cancer genetics. He will be talking about lung cancer epidemiology in the UAE and impact in early detection on cancer survival outcome. Dr. Saeed, the mic is yours.
Thank you very much indeed, Dr. Al-Bastaki. That's very, very kind of you with this introduction. Thank you very much indeed, everybody, for joining us. And thank you to AstraZeneca for sponsoring this meeting. So if you allow me, please, to share my screen. Thank you. So I hope that you can see my screen. So tonight I'm going to discuss the lung cancer epidemiology in the UAE and the impact of the early detection of the lung cancer on the survival outcome of the patients. Can you guess how many patients are diagnosed with lung cancer each year? I just pause for a few seconds so that you can just have a number in your mind. And you'll be surprised that actually each year in the world, we diagnose 1.93 million patients with cancer, with lung cancer. So 1.9 million new lung cancer patients in the world each year. That is a staggering number of patients that are diagnosed with lung cancer. That is equal to 11.4% of all the cancers that are diagnosed annually in the world. In fact, until 2 years or 3 years ago, lung cancer was the leading cancer that are diagnosed worldwide, and now it is the second after the breast cancer. So breast cancer is 11.7% of all the cancer diagnosed annually, and the lung cancer 11.4%, only a very small percentage after the breast cancer. But when you look at the right-hand side of this screen, you can see, although that the lung cancer is now the second most common cancer in the world, it is actually the leading cause of the death in the world due to a staggering number of patients with lung cancer that unfortunately die. 18% of the annual cancer death is because of lung cancer. 9.9 million deaths around the world because of lung cancer. This is really quite alarming. When you look at the United States data, you see that again, it is the second most common after prostate in males, the second most common after breast cancer in female, but in both sexes, whether it is in female and male, it is the highest number of the mortalities caused by lung cancer. When you come to the GCC region, things are a little bit better, thankfully. Lung cancer is not very common in this area. Again, like I said, nearly 2 million new cases of lung cancer worldwide. But when you come to Saudi Arabia, around only 923, that is a little bit of old data. In the UAE, around 190 patients. In Kuwait, around 158 patients annually. So thankfully, it is not as a high incidence as we see in the Western countries. But in some of the other larger area in the Middle East and North Africa, when you look at some countries, some such as Egypt, for instance, it is huge. Again, 56,000 patients they are diagnosed with lung cancer in Egypt. Unfortunately, in some other Arabian countries, it is very common. Looking at the UAE, this is a 2020 data from the WHO. You see that in that year we had around 4,700 patients diagnosed in the UAE with a population of around 9.7 million. And lung cancer was the sixth most common with around 4% of the cases, but still contributed to 8.8% of the annual death from all the cancers. So again, this is the UAE data between some 2008 and 2013. You see that it is fluctuating between 47 to 53. It is definitely not reaching 100 in that year. And certainly when you look at lung cancer, which is in the orange here in this box, around 2018, we had 181 patients diagnosed with lung cancer. It is fairly stable between 2012 to 2018, 181 and 190. But as you can see, it is expected to really go very, very high to around 1,020 by 2040. So that number is not going to stay the same, for all cancers. We see, unfortunately, global increase. But it is really staggering that between 2018 and 2040, which is only around 15 years from now, we will see a huge surge, around 8 times as many as lung cancer, which is going to be diagnosed in this country. So unfortunately, a lot of lung cancers, they are diagnosed at late stages, which are unresectable stage 3 and stage 4. Around 85 to 90% of these patients, they are diagnosed at late stages. And as you can see on this right-hand side of the paragraph, the slides, the 5-year survival dramatically reduces if the cancer is diagnosed at the later stage. When the patient is diagnosed at a stage 3A to stage 4, you see that such a dramatic response. So even there is a huge difference between really a stage 3 and a stage 4. Things are much, much better when it comes to to finding it at an earlier stage, such as a stage 1 and a stage 2, when we have a better survival of the patients. If you look at the overall survival of 5-year survival of all patients with lung cancer, you see that it may be around like 18.6%. You say that, gosh, this is really very low indeed. Only 18% of the patients, they live to see the end of 5 years. But look at this slide. If you diagnose the patient at an earlier stage, when it is stage 1A1, 92% of the patient, they will survive 5 years. It reduces gradually when you diagnose the patients at a stage 1A, 3 to around 77%, stage 1B, 68%, stage 2A, 60%, 2B, 50%, and so on and so forth, until you reach a stage 4A, which is only 10% of the patients, they see the end of 5 years. And unfortunately, when it becomes a stage 4B, which is a metastatic disease outside the lung, it is basically zero. No patient is going to be alive at the end of 5 years. Unfortunately, we are not very good at diagnosing the patient at early stages in this country. This is the data from Tawam Hospital some years ago. As you see, majority of these patients unfortunately diagnosed at a stage 4 disease. 150 patients or 81% of the patients, they were diagnosed at a stage 4, where the 5-year survival is almost zero for this group of patients. Even patients who are unresectable disease, you see that quite a lot of patients really, unfortunately, at this stage. And we almost diagnose no patient or very, very small number of patients at early stages. So this is really quite staggering. We are not very good at diagnosing patients at earlier stages, and we are not able to, unfortunately, offer them curative intent therapy as well. So what causes lung cancer? What are the risk factors for lung cancer? Lung cancer could be caused by quite a few things. Smoking, obviously, this is a very well-known risk factors. Exposure to some of the carcinogens, such as asbestosis, silica, radon, heavy metals, and sometimes in such cases, inheritance. But to be honest, we feel majority of the cases, they are caused by smoking or exposure to some risk factors. This is the data which is really, again, it worth noticing. This is the data from the UAE National Air Emission Inventory Project, which was published in 2019. And I just wanted to draw your attention to this part of this slide. I don't know if you can see it properly on your screen or not. I hope that you have a larger screen. But you can see that 64% of the emission at the particular matter, which are 2.5 microns. And these are small, small particles that can sit inside the lung and can cause inflammation and subsequently cause lung cancer. These are produced by the industry, the traffic that is coming, shipping, and the transport and everything as well. So this is really contributing to a lot of air pollutions that can further contribute to lung cancer. The symptoms of lung cancer. We do not always see these symptoms, and sometimes if you actually see these symptoms, it is far too late. So you should not rely on these symptoms to be able to diagnose the patient at earlier stages, because when you get to the patient that is coughing and having a weight loss, chest pain, having a fatigue, hoarseness, or troubling in having her or his breathing, it is probably too late. But these are the kind of symptoms that you can have from lung cancer. Most of the time, some cough, probably shortness of breathing, and some changes in the voice as well. But again, like I said, if you are detecting these symptoms, it is probably too late, and the cancer has already gotten to the stage that it is not treatable or curable, rather at that stage. How do we treat lung cancer? Unfortunately, treatment of lung cancer is not easy. It is actually a very complex treatment algorithm for lung cancer. From the time of the diagnosis, how we diagnose these patients, multiple different type of imaging that you need to do for these patients, biopsy, sending for molecular profiling, and advanced molecular tests and everything for this group of patients. Getting other specialties such as the surgeons, pulmonologists, pathologists, radiologists involved in there to establish whether it is a resectable disease or borderline resectable, and so on and so forth, or whether it is actually, if it is not resectable, you also need to get other colleagues such as the radiation oncologist with medical oncologists to formulate it. So it is really a very complex treatment program for these patients, especially when it is diagnosed at the later stage. So to be honest, the message from here is that all these expenses and the complexities that comes with the treatment of lung cancer at the later stage can be avoided if we can diagnose the patient at the earlier stages. The treatment of lung cancer has evolved enormously, and we have obviously had some success in terms of the treatment, with targeted therapy and immunotherapy. I can show you some success that we have had. This is a patient of mine which presented with this picture of the lung. You don't really have to be a radiologist or have any medical knowledge to realize that this chest X-ray is an abnormal chest X-ray, very abnormal chest X-ray, really, with this disseminated disease in both lungs. And then this is a CT scan. You see, really, it is a quite a widespread disease. And again, you have to do expensive tests, more advanced tests, such as this PET-CT scan, which shows you that you have disseminated disease not only in the lung, but in the bone as well. You can see that we have disease in the pelvis, in the femur. Here we have it in the spine, and so on and so forth. But this patient we treated with a targeted therapy, and you look at only 5 weeks post, or 2 weeks rather, post treatment, you say that this chest X-ray has dramatically changed. So this is the power of the targeted therapy. Again, this is the CT scan showing really a great response to the treatment. And with this patient, 18 months after initiating on a targeted therapy, has almost a normal CT scan and PET-CT scan with almost complete resolution of all the disease, as you can see, not only in the lung, but also in the bone as well. But really, this is not the case for all of our patients. And even this patient, although that he had a very, very nice response to the treatment originally, but eventually, unfortunately, this patient had a recurrence of the disease and things started to progress. So the best thing is actually to try to screen and detect the patient as early as possible, so that we can offer these patients curative intent therapy rather than palliative therapy. So the message is that lung cancer can be cured if it is detected early. So catching it at earliest stage, we can offer this patient a cure rate as high as around 80 to 90%, as I showed you in the previous one. And this cure rate is actually dramatically drops if the cancer is diagnosed at a stage that it has gone to the lymph node or other part of the body as well. So again, we can definitely rely on some of the symptoms, such as the persistent cough or hoarseness or breathlessness or weight loss or a loss of appetite and fatigue. But in all honesty, these symptoms, they are non-specific. So they are not really, at the time that we diagnose these patient with these symptoms, if you wait to have the patient at this time, this is really at a stage that these patients, they are not curative. This is why some of other measures, such as low dose CT scan, this is a way forward, perhaps painless, less invasive, with a low dose of radiation that makes the screening feasible and treatment of patients at earliest stage possible, where we can actually offer these patients curative intent therapy. So we really need to raise awareness about this. We need to get engaged. We need to learn about the facts, and the facts are the ones that if we diagnose patient at the earliest stage, we can offer curative intent therapy to 80 to 90% of this patient. Please spread this word, share these stories. It is important that we basically focus our efforts on early diagnosis of the patient, rather than getting into that complex algorithm that I showed you, which is for the advanced patients. And often, even with those complex treatment, it is impossible to cure this patient. With that, thank you so much indeed for your attention, and I would be very happy to answer any question that you may have. Thank you.
Thank you so much, Dr. Saeed, for the great valuable presentation and a great introduction for what is coming next. So next speaker is Dr. Ahmed Malik Mohammed. He's a consultant radiologist with broad experience across multiple aspects of general radiology and cross-sectional imaging. He has completed his postgraduate training in the United Kingdom, where he worked as a consultant for several years. During his time in the United Kingdom, he has participated in a lung cancer screening pilot program and was one of the reporters. He is a fellow of Royal College of Radiologists of the United Kingdom, FRCR, and hold active membership in the Radiological Society of North America, RSNA, and European Society of Radiology, ESR. Dr. Ahmed will be speaking about lung cancer screening from his experience. Dr. Ahmed, mic is yours.
Good evening, everyone. Thank you, Dr. Osama, for the introduction. My name is Dr. Ahmed. I'm a consultant radiologist in Mediclinic Parkview Hospital. If I can be allowed to open my video, and thank you. Okay, so lung cancer screening is an interesting topic. It's relatively new and rapidly evolving. I will try to summarize the important literature and shed some light on practical points in the next 15 minutes. Now, I have been a previous reporter in the lung cancer screening pilot, and some of the practical points in which I will talk about reflect my own experience and the experience of the center where I've worked rather than general guidelines. Epidemiology has been nicely covered by my colleague. So the next question would be, what is lung cancer screening? In this side of the screen, you will see stage 1A cancer. At this stage, basically it's a small nodule. And this is the stage where we would like to detect cancer at. In the left-sided 3 images, this is advanced cancer, stages 4A and 4B, where it has grown to invade the mediastinum and adjacent vasculature. Now, unfortunately, as my colleague stated, a large proportion of lung cancers currently are diagnosed in late stages, stage 4A and 4B. At this stage, the 10-year survival is very poor, 10% and less. Compared to the 5-year survival in this side of the screen, which is stage 1, which exceeds 90%. So lung cancer screening basically is diagnosing cancers at this stage in order to avoid this stage and gain massive improvements in 5-year survivals and patient cure. Lung cancer, as my colleague mentioned, it's the #1 cause of cancer-related deaths worldwide. It is more deadly than breast cancer for females, and more deadly than prostate cancer for males, and more than colon for both genders. Nonetheless, we have established and successful screening programs for all 3, but not for lung cancer. So the question that begs itself is why has it taken so long for lung cancer screening to develop and is still developing? To answer this question, I did a literature search and found 3 studies between the years of 1970 and 2000. These studies are listed below. At the time of these studies, the readily available tests for lung cancer were chest X-ray and sputum cytology. These 3 trials concluded that both these modalities had offered no reduction in mortality when compared to the control groups. Hence, at that in that generation, no one bothered, but at least these studies paved the way to future studies. In the last 20 years, as we all know, CT has become more available, more prevalent, more accessible, and more affordable. So new studies started to shed some light on CT. I will touch on a few practical points as well and challenges that acted as barriers in a later slide. These were also reasons for delaying the development of lung cancer screening. One of the landmark and groundbreaking papers is this paper, which is a paper published in 2011 in the New England Journal of Medicine, the National Lung Cancer Screening Trial in the USA. It remains the largest lung cancer screening trial ever done, and one of the first to assess the impact of volumetric-based low-dose CT. It's a good read for everyone who is embarking on lung cancer screening, and I would highly recommend it. This study, it's a large randomized controlled trial across 33 centers in the USA. It recruited 54,000 patients between the ages of 55 and 74. All these patients were either current or former smokers. The patients were randomized into low-dose CT scan and chest X-ray groups. Both groups underwent 3 annual image surveillances. The study found greater incidence of lung cancer diagnosis with CT, obviously, with more than half of lung cancers diagnosed in stage 1A. More importantly, however, it found a 20% lung cancer mortality reduction with CT. If we look at the mathematics behind it, so basically we need to scan 320 patients in order to prevent one lung cancer screening death. Compare this to breast, where we had to screen 746, and to colon, where we have to screen more than 1,000. This sounds like a very good deal in favor of lung cancer screening. In the interest of fairness, one of the main concerns with this study was the high false positive rates, which I will speak about later on. Now, a few practical points about low-dose computed tomography. As the name says, it's an uncontrasted study obtained with a multi-detector CT scan during a single inspiratory breath hold. The screening time on average is around 25 seconds. It is a high-resolution study with scan intervals of 1 to 2.5 millimeters. Images are reconstructed using a special algorithm. The estimated effective radiation dose for a low-dose CT should be around 1.4 millisievert, compared with an average radiation dose of 7 to 8 for a standard diagnostic CT chest. That is quite a good dose reduction compared to chest radiographs, which is around 0.1 millisievert for both PA and lateral views. So those sounds looks reasonable. Now, since the New England Journal of Medicine paper, multiple trials and pilot studies were performed in different countries around the world, across the US, Canada, UK, and Europe. One study worth mentioning is the Nelson study, which was conducted in Europe. It's a Dutch/Belgian study. The different thing about this particular trial is that the control group was offered no screening at all. Scan rounds were in years 1, 2, 4, and 6. The sample size was smaller compared to the previous study, around 13,000 patients, but nonetheless still a large sample. Similarly, the study found a greater incidence of diagnosis of lung cancer in early stages and a better overall mortality reduction of over 25%. Of note, over half the patients in the study group were diagnosed in stage 1A, whilst over half the patients in the control group were diagnosed in stage 4. So that again goes to show the value of early detection and the difference that it will make to patient survival. Following the Nelson study, institutions around the world said, okay, lung cancer screening works, and more trials were performed and guidelines started to emerge. There's a good systematic review of the main 7 trials in lung, which was published in the European Journal of Cancer. It summarizes the main 7 trials that were conducted with regards of low-dose CT in lung cancer screening. The main differences between trials and studies across different countries, and obviously the most important question is who should we screen? There were variations in risk assessments and selection criteria, but overall they revolved around age and tobacco exposure status. It is proven from previous studies that screening is typically more effective in high risk groups. All studies had a system in place to assess patients prior to offering screening. In the UK, the system we call it a total lung health check. This is mainly used to apply exclusion criteria and make sure all patients meet the guidelines for screening. Now, now that we've established the background evidence behind lung cancer screening with low-dose CT, the next question becomes is how do we set up a lung cancer screening service? Now, answering this question is a talk by itself, but I will quickly go through the next slides to give an idea of the different factors and criteria that are needed to run or set up the service successfully. The main thing to understand is that lung cancer screening is not a single test. It is a process that involves annual testing and follow-up of abnormalities. It needs an experienced and highly trained team, a multidisciplinary team, including nurses, respiratory physicians, different types of radiologists, and a tumor board, along with all the PA staff. All need to be highly trained and well aware of lung cancer and its implications. The hardware obviously needs to be safe, needs to be effective, it needs to keep radiation to the minimum, and it needs to ensure consistent and reproducible image quality. We have touched on the radiation dose in a previous slide. Now that we've got the team, we've got the hardware, we need software to get the system working. So I'm referring now to the radiology software. So lung cancer screening is a volumetric-based study. So it's essential to have software that will allow volumetric assessment, not just 2D measurements. In the UK, computer-aided detection was also essential and makes a huge difference to the speed in which you can report these studies. Now, the reporting itself, the implementation, it's again this. So as I previously mentioned, it's a program that relies on follow-up imaging. So a dedicated CT reporting proforma is essential. That would facilitate accurate comparisons and follow-ups in future scans. It has to give emphasis to nodule volumes and different characteristics. As with any screening program, a lot of incidental findings have come up in these scans. Very clear protocols to manage them are important. The commonest being emphysema, bronchiectasis, different types of ILD, coronary artery calcification, and aortic valve disease. Obviously, PA software is required to tie everything up together, appointments, patients, health records, and so on. It needs to be a suitable software. This is quite an important slide, despite being a simple one. The one thing that I've noticed across all the trials for lung cancer screening is that all of them offered a form of smoking cessation service. Lung cancer screening is not a substitute to smoking cessation, which is the highest risk for developing the disease. And nearly all cancer screening trials incorporate smoking cessation somehow. So that should be included within the implementation part of any lung cancer screening trial. Now, whenever we introduce everything new in medicine, quality assurance comes into light. Obviously, with it being a new modality introduced, everything will need to be audited, and radiology reports, preferably double read, at least initially. In the UK, any radiologist joining the program would have the first 50 scans at least double read by other radiologists. Now, I have mentioned there are different pathways, guidelines across the world. So just for example purposes, this is the pathway that we used in our pilot program in the UK. There's a lot to say about this slide. At the end of the talk, if we have time, I'll come back to it. But generally, patients would be invited to a lung health check, depending on specific criteria. If those patients are established to be high risk, they would then be invited to have a CT, a low-dose CT. These are the criteria that we used to monitor and establish the follow-up intervals for CTs. We relied heavily on the Brock risk factor model, which is readily available online. I'll come back to this slide for further details if the audience wants that at the end. Now, I mentioned at the beginning, there were multiple barriers to introducing lung cancer screening. Now, these need to be addressed as part of implementation. So the guidelines are there, recommendations are there, but it's taking long to implement, as I've earlier mentioned. So what are the barriers? Again, I've reviewed the literature to establish different types of barriers. Lack of awareness is a main one. People don't know that there's a lung cancer screening program that may be offered. The clinicians as well, because it's not a new or developing field, they're unfamiliar with the guidelines. So unfamiliarity of clinical staff with guidelines, lack of patient awareness. It's not as prevalent as the breast cancer screening program, for example, where all females above a certain age know to go and get mammograms. Despite CT becoming more prevalent, there remain access challenges. These studies require scanning time and reporting time from a workforce that is already under pressure. And obviously, cost concerns come into question. There's a different slide about this later on. Now, are there any risks with lung cancer screening? Yes, of course there are. All the randomized controlled trials had a relatively high false positive result, which was associated with short-term increase in distress. These false positives may undergo evaluation by needle biopsy and/or surgery, which comes with its own morbidity and mortality. Some nodules required prolonged periods of follow-up, often lasting several years, and which may cause added anxiety to the patient and fear of having lung cancer. An interesting one is overdiagnosis. As we all know, overdiagnosis is as bad as underdiagnosis. So that was something that needs extra attention when it comes to setting up guidelines. Incidental findings I've explained in a previous slide. With any imaging modality, there's a lot of anxiety about radiation doses. So approximately low-dose CT, as previously mentioned, it's equivalent to 12 chest X-rays. By chest X-ray, I mean a 2V1 AP and lateral, which is still a relatively low dose and certainly indicated if you measure up the benefit-risk ratios. Now, going back to cost effectiveness, which is a valid question asked by...
We have 1 minute, Dr. Ahmed.
Okay, so going to a valid question asked by different health boards. There's a study which in the Journal of Thoracic Oncology, which is a good read that answers this question. It showed that it could be cost effective in multiple regards. I will leave that for you to read. Another good paper for everyone to read is a paper by Gould, which is published in the New England Journal of Medicine. With time restraints, I won't go into details, but it raises multiple points interesting for discussion. I would recommend you take a screenshot or a photo of this slide and read these points in your own time. So future directions of lung cancer screening. We need better risk prediction models, especially with the recent trend of lung cancers in never smokers. Molecular and genomic analysis is a growing field under the name of liquid biopsies. This could certainly have a value in the future. And AI, as we all know, is taking over the world, not just lung cancer screening. So I hope you found this talk useful and shed some light on the background of lung cancer screening, its implementation and the barriers behind it. And also its huge value and indications to have it established. A few take-home points are written here. Keep in mind, lung cancer is the #1 cause of cancer deaths in men and women worldwide. So having a screening program is certainly worthwhile. I'm happy to take any questions from the audience. And thank you very much.
Thank you, Dr. Ahmed and Dr. Saeed. By the way, you have questions in the Q&A answer of the chat box. If you and Dr. Saeed can answer them by writing, it would be nice. By meantime, we have the next speaker. So next speaker is Ms. Shami Kumar. She's highly experienced diagnostics radiographer with over 15 years of clinical expertise spanning all areas of radiography. Graduated from City University London in 2009. Her professional development includes advanced study in leadership, management, and counseling, and the current role as Senior Director, Clinical Specialist in Artificial Intelligence in Radiology. She actively shaped the future of radiology and artificial intelligence through her role on AI Advisory Board, guest university lectures, and through involvement in multi-site research study, where she has been recognized an expert in AI with radiology. Shami will be talking about AI in healthcare. So Shami, the mic is yours.
Thank you, Dr. Sama, for that kind introduction and having me this evening. I'm just going to share my screen. Hopefully my screen is visible to everybody. So I'm going to be talking about AI in healthcare. I will be giving a general overview of AI, and then we will focus a little bit more on lung cancer, more more on chest X-rays. So just a little bit of background on the AI technology and the company that I represent. So the company is called Cure AI. We are one of the world's most adopted AI software in the world, and we are deployed in 90 countries, 3,200 sites. And we have multiple publications. We have a very big team of AI scientists and engineers who've developed the AI algorithms. We are also recommended by WHO, and we have several partners throughout the world. So just to give you an overview of some of the AI products, the first one is chest X-ray. So this is where AI will identify various abnormalities on the chest. It will provide a contour, so an outline as to where the abnormality has been found, and it will call it either normal or abnormal chest X-ray. The other one is head CT. These are more sort of critical findings of ICH bleeds, midline shift, mass effect, fractures in the brain, things that need sort of urgent attention and care. The other one is chest CT. So these are more around nodules. So the AI will actually identify nodules. It will automate some of those manual processes that a radiologist would do. So it would quantify, it will give you the volume doubling time if there was any previous images, and it will monitor the nodule over time. It can also pick up any incidental findings as well, incidental nodules. The other one that I just very quickly wanted to mention was QMSK. So the AI would actually detect fractures. So it will say fracture or no fracture on all sort of MSK fractures. And this is more to support sort of A&E clinicians patients coming through A&E, where there is not a radiologist available 24/7, and the AI becomes that second pair of eyes. So just to focus on chest X-rays and lung cancer a bit more. So QXR is being developed on 9 million images training data set. So we all know that the data quality and the number of data sets that an AI algorithm is trained on is very important. It gives you better accuracy, sensitivity, and specificity. So we have 9 million data sets that we've trained the algorithm on. It's been captured from various countries like Europe, UK, Asia, India, US, to give that sort of prevalence and diversity in the data set. It does detect normal and abnormal, so it will give you a normal or an abnormal tag. It will detect findings that are suggestive of lung cancer, and we'll go into that into a little bit more detail. It can prioritize your list. So radiologists have multiple chest X-rays that are on their work list. And as we all know, that chest X-ray is first-line imaging. So the AI would flag an abnormal chest X-ray, maybe turn it a red to say there is something suspicious on this chest X-ray. Look at this chest X-ray first, report this chest X-ray first. So if there is something suspicious of lung cancer, this patient would have an earlier diagnosis. It can also pre-populate a report. So any of the AI findings can be populated into a radiologist report. The report can be edited and changed by the radiologist and then verified. So QXR is the first AI software to be recommended by WHO. It can be used in the absence of a human reader. So not all countries have the benefits of having radiologists, clinicians, doctors looking at chest X-ray. And WHO has made the recommendation with using QXR for TB screening. There is no need for a radiologist. So what are the use cases for QXR AI in lung cancer? So there's multiple use cases. It's about what we are trying to define and solve for the hospital or the country that we are working with. So AI can be used to prioritize the reporting. So if the AI picks up anything suspicious of lung cancer, it can prioritize this for the radiologist to look at this first. It can reduce time to CT. So if that patient is reported first, then the patient can be sent for a CT scan earlier than they would have without AI. It can reduce time to diagnosis of lung cancer. It can support incidental findings on a chest X-ray from a general patient pathway. So if a patient is coming through in having a chest X-ray for, say, a cough that they've had for the last 3 to 4 months, AI can be that second pair of eyes to pick up something that can be very subtle on a chest X-ray. And the idea is that the AI will help to detect early lung cancer, as we've heard from some of the previous speakers. Capturing lung cancer in its early stages is beneficial to the patient. There are better treatment options and survival rates. So this is an example of how the AI, once it's integrated into your hospital systems, this is what it would look like. If you have a look at the top of the screen, you would see here, we can actually put the AI can categorize the chest X-rays. So in this example, we have abnormal urgent cancer, abnormal urgent non-cancer, abnormal non-urgent, and then normal. So whilst you might think, why is there 4 categories on there? Essentially, not everything flagged by AI is urgent. It could be, yes, it's abnormal, but it's not critical. It's not suspicious of lung cancer, meaning it could maybe wait to be reported later in the day, but let's pick up the urgent suspicious cancer patients first. So we can actually put the various findings into categories how you see fit as clinicians. At the bottom here, you'd see 2 chest X-ray. So one would be the original chest X-ray itself, and the second one would be the AI secondary capture. And I'll show you a slightly enlarged version of what the AI secondary capture would look like. So this is another example of prioritization. With this customer, what we did is that they wanted multiple flags and colors to represent different findings that were relevant for the hospital. So here you'd see the red flag would mean TB presumptive, green would be no signs of TB, abnormal, and then COVID-19 risk. And as you hovered over the patient, you'd see an AI output. It would give you, contours and suggestive findings. This is another example of what it would look like on your PAC system. So you'd have your chest X-ray here, and this is what we call an X-ray overlay or an AI secondary capture. You'd get a normal tag from the AI here, and here all the individual findings that it's capable of, and either a yes or a no against this. There would be a disclaimer at the bottom, so anyone that has access to a PAC system, they would know that this is an AI secondary capture, and this is not the original chest X-ray, and that this is an AI interpretation. This is an example of an abnormal one. You would see an abnormal tag here at the top. The AI will provide a contour around where it has found the abnormality. In this instance, it's saying opacity nodule. It says nodule in brackets simply because opacity is a very generalized umbrella term, so it defines this a little bit further for us. Here on the other side, you'll see all the findings and whether they are present or not. Now, this is an example of a subtle case that I wanted to share with everybody. The idea behind AI is to become the second pair of eyes for doctors, to pick up those subtle findings, but also to capture early lung cancer diagnosis. So in this example, this is a very subtle lung cancer case, and I'm just going to show you where AI has supported. You will see that AI has found a nodule here at the top. It's given a contour, and this patient was diagnosed with stage 2 cancer. So this is what an AI-assisted workflow would look like as part of the lung cancer pathway. So you would have all chest X-rays flowing, whichever pathway that the patient comes through or comes and sees at the hospital. So this could be from your primary physician, GP, through A&E or inpatient or outpatient. The patient goes on to have their chest X-ray. Once the chest X-ray has been completed and sent to PACS, we actually receive it on the AI software. It is processed on the AI algorithm, and the algorithm produces various outputs. So it can put it into the categories, which I shared earlier. So it can have a green flag, a red flag for abnormal, and then it can even have a third flag for those suspicious cancer ones. And then these patients would be hot reported or reported that same day as early as possible, and the patients can get put on an accelerated pathway and onto CT. So AI feedback is very important for us. One of the often questions we get in AI is, what if there is a false positive? What if there is a false negative? Yes. So AI is not going to be 100% correct. It makes mistakes. As much as we can try, we try and get the highest sensitivity and specificity we can. It's important we understand the prevalence of the country, the hospital we're working with, and make sure when we first deploy that AI algorithm, it is performing to the way it should be. If it's not performing, we need to make sure we capture which cases are coming up as either false positives or negatives. In the instance of lung cancer, we don't want AI to miss anything. So we don't want to see any false negatives. So we ask a lot of the time the hospitals to share feedback with us about which cases is the AI missing. So that way we can do a various very small threshold adjustments. For example, if the AI keeps missing a nodule which is behind the heart, we know that, you know, AI is making this mistake. Either we need to upgrade the model to give the latest version. Do we need to change the threshold and drop the threshold a little bit so it becomes a bit more sensitive? What is it that we need to do to make sure that the performance is where it should be? So a lot of the hospitals that we've worked with can integrate an automated system or an automatic way of receiving feedback or sending feedback to us as a company. So if you have a look on the screen here, there is a drop down and it says here true positive, false negative, and so on. Here you could do the same. False negative is always something that we are very interested in, and it's important we get that right. There are some hospitals that like to have free text. So you can have a click button to say, yes, this was an AI discrepancy and AI got it wrong, but then they can share a bit more details around, you know, what is it that AI got incorrect. And over time, we collect this feedback and work with the hospital to make sure that their AI is supporting them the way it should. Thank you very much for your time and attention. I hope that was useful.
Thank you, Shami, for your valuable input. So we go for the next speaker. Next speaker is Dr. Zainab Al-Balushi. She is a distinguished radiologist with a strong background in medical education and clinical practice. She obtained her MBBS from Ras Al Khaimah Medical and Health Science University and completed her residency in prestigious Dubai Health Hospital. She featured her expertise by earning her specialization from the Arab Board of Health Specialization in Radiology with a passion and advanced medical knowledge and patient care. She is dedicated to share her expertise as a speaker about how AI is reshaping diagnostic and patient management, as well as ethical consideration that comes with the advancement. Dr. Zainab, mic is yours.
Assalamu alaikum and good evening, everyone. Thank you for this nice introduction, Dr. Osama. Most of my talk has been already covered by some of my colleagues. However, it will be also nice to add more to their talks. So in 2015, Elon Musk tweeted that you'd be able to summon a Tesla from across the country within 2 years. And in 2016, Jeffrey Hinton, who's pioneering deep learning, claimed that we should stop training radiologists. It is just completely obvious within 5 years, deep learning is going to do better than radiologists. However, now we are at the end of 2024. radiology training programs being held all over the world, and also radiologists are going to their work using normal cars. So still the timeline is not being obtained for AI to take over radiologist or healthcare professionals' job. Let's be positive and don't think about that way. Actually, AI will help to improve patient outcomes, reduce cost, and also enhance the overall efficiency of healthcare delivery. With that said, we want to know what is an AI X-ray screening program. I'll be speaking in general and also in terms of the AI program that we are using in both Rashid Hospital and the PHC. So the AI X-ray screening program typically refers to the use of artificial intelligence technologies to enhance the analysis of X-ray images, particularly in the medical setting. These programs are designed to assist radiologists in detecting and diagnosing conditions such as nodules, fractures, tumors, and other abnormalities more accurately and efficiently. An AI algorithm can analyze X-ray images quickly and highlights areas of concern. In our case, a Curie obtains the images within 1 minute and also highlights the areas of concern, whether they are nodules or opacities, and also say whether they are high risk or low risk. And also assisting healthcare professionals in making faster, more informed decisions. And integration of AI in radiology can also improve the accuracy of diagnosis, reduce the workload on radiologists, which is an important aspect also, and also help in identifying conditions that might be missed by human eye. Here comes the big question that everyone is asking. Can AI be used autonomously, safely in medical reporting and medical field? The short answer is yes. However, several considerations should be kept in mind to use AI safely, accurately in medical field. So we have these at least 6 points. We are going to go through each one of them. First of all, accuracy and reliability. An AI system needs to be trained on high-quality, diverse data sets to ensure that they can accurately interpret medical data and create reports. In our case, CurieX was trained for 4.2 million data sets, which are of diverse backgrounds and diverse demographics, which is very suitable for our region in UAE, as we all know that we have a diverse background. So continuous validation and updating these modules also is necessary in maintaining the accuracy. Second, regulatory compliance. Any AI system used in healthcare must comply to regulations and standards set by health authorities, either local or also international. These will ensure that the technology meets safety and efficiency standards. So Curie is being certified by Food and Drug Administration, European Conformity, and also Technical Inspection Associations. Human oversight. While AI can assist in generating reports autonomously, having a healthcare professional reviewing the AI-generated reports is crucial for critical decision-making. I personally think that the hybrid approach is the best method in order to mitigate the risk associated with AI errors. Patient safety is also a very important part. Ensuring patient data is protected during AI reporting process is vital. Curie complies with Information Security Standards, Health Insurance Probability and Accountability Act, also General Data Protection Regulations. Bias and fairness. AI can learn bias from training data, so it is essential to actively monitor and address bias to ensure fair treatment across patient demographic. Here comes also the importance of hybrid approach while using AI. Last but not least, users training. Healthcare professionals require adequate training to effectively use AI tools to understand their capabilities and limitations to make informed decisions. Even if your healthcare provider is not using AI in generating reports or in your daily workflow, it is very important for healthcare professionals to have a regular um, meetings and going through researches in order to see the limitations and capabilities of AI. Also, they can compare their capabilities and limitations when coming to AI. In conclusion, the integration of AI into healthcare represents a transformative shift that promises to revolutionize patients' care by improving the efficiency, accuracy, and speed of medical diagnosis and reporting. However, for AI to realize its full potential, it must be implemented with a clear strategy that includes regulatory compliance, ethical consideration, and reposting security measures to safeguard patients' data. Continuous oversight is equally critical to ensure that AI system remains accurate, unbiased, and aligned with evolving medical standards. The collaboration between healthcare professionals, AI developers, the events that we are doing today, and the very recently events that have been involved, and bodies will be vital for fostering an environment where AI serves as a trusted tool to enhance patient outcomes while maintaining the integrity and safety of care delivery. Here are several notable case studies. I got these case studies only from sources. Most of them are from 2020, where the timeline set for the peak AI taking over the medical field. So the first one is lung cancer screening with low-dose CT. The national lung screening trials demonstrated that low-dose CT scan could reduce lung cancer mortality by about 20% compared to the chest X-rays. An AI algorithm has been developed to further enhance the detection of lung nodules in CT scan, as mentioned by my previous colleagues also. And this research that's shown that AI models can identify lung nodules with sensitivity rates exceeding that of human radiologists. For example, it is reported that AI models achieved a sensitivity of about 94% in detecting lung cancer nodules, which is a very high percentage, surpassing the performance of radiologists. Second, mammography for breast cancer detection. A study published by JAMA Oncology in 2020 evaluated the performance of AI in analyzing mammograms. The study involved nearly 25,000 mammograms, which showed significant reduction in false positive and false negative values by 5.7% and 9.5% respectively, compared to human radiologists. This study suggested that AI could support radiologists improving breast cancer screening accuracy. Third one is CT imaging for colorectal cancer. Researchers also published by Gastroenterology in 2020 explored the use of AI algorithm to detect colorectal polyps during CT colonography. The AI was able to identify polyps with a sensitivity of 94.5%, while human radiologists had a sensitivity of 86.3%. The integration of AI improved overall detection rates and could also help mitigate the risk of missed cancer. Last, the AI and MRI for brain tumors. A study published by Lancet Digital Health in 2020 evaluated an AI model that analyzes MRI scans to detect brain tumors. It demonstrated a high accuracy with sensitivity of 95% for detecting brain tumors, which is particularly significant in given complexity of the brain. These are some of the examples about AI used in different modalities in radiology field. However, there are more other research which are open for the individuals to go through. These are the ones that I found, which are all from open sources, and mainly, if you notice, they are from 2020, where the timeline set by vendors and pioneers in AI, that AI is going to take over the medical field. These are my references, and if you have any questions, you can drop them in the question and answer box. Inshallah, I'd be able to answer them. I want to mention that we are using a query AI in Rashid Hospital and PXC. However, we don't have until now autonomous reporting. All the reports are being radiologists. So still we don't have a full autonomous reporting, at least in Dubai Health for now. Thank you for having me. And if you have any questions, you can drop them in the question and answer box. Thank you so much.
Valuable inputs. So I advise you to read the question and answer. There are a lot of valuable inputs from Dr. Saeed, Dr. Ahmed, and from Shami as well. So our last speaker is Dr. Mohammed Ukasha. He's a specialist radiologist at Peripheral Health Clinic Dubai Health with over 14 years of experience in radiology. He's a member of several professional societies, including the Egyptian Medical Syndicate and the Egyptian Society of Interventional Radiology. Dr. Mohammed, mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Osama, for kind introductions. Good evening, everyone, and thank you so much for joining us, lung screening in UAE. I will share my presentation. My presentation, you can see my presentation?
Yes, Mohammed, we can see your presentation.
Okay. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Today, inshallah, we'll share our experience of using artificial intelligence for detection and characterization of pulmonary nodule for screening lung cancer in Dubai Health. We done this project, me and Dr. Zainab, under supervision of Dr. Osama. We started this project last year in many phases. First phase for 6 months. AstraZeneca and Corey AI have partnered with Dubai Academic Health to start an early lung cancer detections project for a 6 months duration. A chest X-ray based software will be used to detect pulmonary nodules on a chest X-ray performed in the Rashid Hospital and the Primary Health Care Center. This project focuses on improving the cancer surface delivered by reducing the missing nodules and the delayed diagnosis of the lung cancer. Especially, it aimed to detect of suspected lung nodule on a chest X-ray of the patient from all pathways, symptomatic as well as asymptomatic, for both at risk and non-risk population. This project will initially started in Primary Health Care Center and the outpatient pathway in the Rashid Hospital in Dubai. We done AI performance at Dubai Health. We done approximately in the first phase 5,000 chest X-ray reviewed through the Primary Health Care Center and Rashid Hospital by radiologists, as well as reviewed by the artificial intelligence. 70% was normal chest X-ray. All normal chest X-ray correctly identified by the artificial intelligence. Good in detections. Artificial intelligence detected 9% high-risk nodules, resulting in 20% to confirmed cases, highly sensitive in nodule detections. Only 1% was false negative due to hidden areas of the lung, especially through cardiac area and lung bases. Differentiation between the nodule malignant nodule and tuberculosis on the artificial intelligence is required because there is too much overlap in the first stage between the pulmonary malignant nodule and the TB nodules. Phase 2 of the study, inshallah, will include updated the artificial intelligence and more training for supporting us to detect and differentiate TB from the malignant pulmonary nodules. How the artificial intelligence work? First, the artificial intelligence detected the abnormality here. This, for example, detected there is abnormality here, and then put annotations. After this put annotation, it started to characterize the lesion. Characterization of the lesion depended on many lung malignancy score, depended on the size, greater or lesser than 10 millimeters, depended on the presence or absence of calcifications, depended on the texture of the lesion, homogeneous or heterogeneous, and the border of the lesion is speculated, smooth, lobulated, like this. Here, this is detected the size, here the homogeneity and the texture, here detected the border of the lesion speculated, and the presence or absence of the calcification. Regarding this criteria, the artificial intelligence give data here like this, lung, there is abnormality. What is the type of the abnormality, opacity or nodule? After this characterized this nodule, it is high risk or non-high or low risk malignancy. This example for artificial intelligence detected malignant pulmonary high-risk pulmonary nodule. Here you can see this is faint pulmonary nodule in the right middle lung zone. He detected, first detected, then put annotations on this, and then analyze this data regarding to the lung malignancy score. Here is there is opacity. Yes. What is the type of opacity? Is this nodules? What is the type of the nodule? Malignant or low risk or high risk? This is high risk nodule. Another example for the artificial intelligent pulmonary lung nodule metastasis detected on both lung field. There is multiple nodular patches here and right and left. He detected annotations, put annotation and detected the nodules, good in detections, and characterized what is the type of the opacity, this is nodular opacity, what is this is high risk or low risk. Yeah, high risk malignancy. This patient approved, this is metastatic deposit. There is false negative and false positive in the artificial intelligence. False negative is most important than false negative, false positive. False negative, we detected only 1%, 50 case from 5,000 case. Why the artificial intelligence give false positive? Because still the artificial intelligence not detected the hidden area of the lung, especially lung basis cardiac area. This example for the false negative. Here is there is retrocardiac patch. The artificial intelligence gives this normal X-ray, no abnormality. Thank you. Our project outcome, there is a clinical value and research value. Clinical value, we reduce the misdiagnosis. Artificial intelligence can act as a double reader for all chest X-ray to reduce the risk of missing and subtle finding or incidental finding on the patient X-ray. And early cancer, artificial intelligence for nodule can help and flag the missed cancer or prioritized cases for faster and follow-up and further imaging. Research values, a strong focus on early detection of the lung cancer and improving patient survival. This project will generate regional evidence of the cancer diagnosis, additional cases begged from lung cancer pathway. Thank you so much.
Thank you, Muhammad, for the presentation. I think we answered all the questions in the Q&A, most of them. So So I have two questions, maybe, but we use the time remaining. We can answer the questions. So there is a question from Malali. So this is good question for all radiologists maybe, and even Dr. Said. So will AI implementation affect the scope for job for radiologist? So anyone who wants to answer, maybe Shami can answer that.
Yeah, sure. So AI is an assistive tool. That's what we have regulatory clearance for. So it's not there to replace anyone's job, it's to enhance your role. So if we just give an example of normal versus abnormal, if the AI can prioritize and just the abnormal cases, and the radiologist can focus just on reporting all the abnormal cases, and say the normals can be reported by somebody more junior. This would allow consultants, doctors, radiologists to maybe focus more on patient-facing interventional procedures in radiology. So there's many ways that you can look at how AI will affect the scope of your jobs, but it's definitely not there to replace you. It's more of an assistive tool to enhance and optimize currently what you're doing. I hope that answers your question.
Yeah.
I agree with Ms. Shami. Definitely, at this point, AI is not replacing radiologists' job. However, it is improving the quality of the reports and the information delivered by radiologists. And also, let's remember that radiologists have a burnout. Having AI on board can help with that also, reducing the workload in the radiologists and allowing them to focus on more complex cases which have abnormalities, rather than going through all the cases which have normal and abnormal chest finding. So at this point, it is actually a positive tool rather than scaring people and scaring healthcare providers that it may take over their jobs. At this point, AI, honestly, it's facilitating the radiologist job.
Okay. There is another question, maybe that's for you, Zainab. How reliable is AI for screening process from your experience now? Or Muhammad as well can answer the question as well.
I believe AI is a very effective tool in screening specifically for lung cancer. However, that low dose it is superior than the X-ray and detection of an early detection of lung cancer specifically. How, even though it is the first modality or the modality of choice in screening the lung cancer, I believe that low dose CT, also the researchers and other publications support that low dose CT, it is a superior to X-ray X-ray in detection of lung cancers and lung nodules.
Yeah. So there is, I think there is a good input from Dr. Lotfi that he said that as we are going further for the screening program, it's good to have the double screening, maybe the same way we are doing with the breast cancer for lung cancer. So this is maybe good input for the future for considering for screening that it goes through double reading as well. Okay, and then there is another question for anonymous attendance about dealing with the screening, and then with insurance as well. If insurance will accept that someone do a screening, well, currently we have a screening program with national screening program for mammography, and somehow the insurance company has adapted this. So currently we don't have official national screening program for lung cancer in UAE, but somehow there is an awareness of from insurance company if this is implemented through authorities especially from Ministry of Health, people will follow for screening for that. So this, I think that Dr. Ahmed already answered about lung biopsy question. Especially how regular screening will decrease the rate of cancer in the future. Well, I think this is dependent on how much you are dealing as well. So it will be something similar to breast cancer. Early detection has helped to in treatment of many cases for this breast cancer. Okay. What about any of the speakers has an input before we close the session?
Maybe regarding the last question by Ayaz, he's asking what about the anatomical variation and can be misinterpreted? Yes, it can. It can be picked up as a false positive findings. Example for that, let's say for chest and azygous lobe can be picked as a nodules. Also, nipple shadows also can be for an example. But here comes the importance of hybrid approach for when using AI tools. Thank you.
And just to add to Dr. Zainab's point, it comes down to the data training of the algorithm. So if the algorithm has been trained on data that has these artifacts and variants, then the algorithm is familiar with it and it will pick it up. And it will no longer call it a false positive. So it very much comes down to the training of the AI algorithm and how robust it is.
So this is the last question. This will be for Dr. Ahmed, as he has experience with lung cancer screening. So the question is, for a smoker, when do we start screening him for lung cancer? And after how long we'll do follow-up?
Sure. So as I've mentioned thank you for the question, first of all. As I've mentioned in the talk, guidelines are still emerging when it comes to patient selection and exclusion criteria and risk prediction models. The biggest trial ever done in lung cancer, it included patients between the ages of 55 and 74, current or former smokers. By current smokers, people with 15 pack year or more. And by former smokers, people who stopped smoking within the last 15 years. Those were the criteria for inclusion within the New England Journal of Medicine that was published in 2011, which is the largest. The subsequent studies, the Nelson and the 6 other studies, they had different criteria. Most of the criteria revolved around age, above 55 onwards, up to 70 and up to 80 in some studies, and all agreed. I think all of them had a smoking pack here of 15 or more, not less. The frequency of follow-up, it was annual. The only study in which it was done more than once a year was the New England Journal of Medicine. The other studies all did it in an annual basis. The pilot program in the UK that I followed, we had a specific risk assessment model that we combined with a risk assessment calculator, and we established the durations of follow-up. For high risk, this would be after 3 months. For intermediate risk, after 6 months. For low risk and for negative scans, it would be after a year. So it's difficult to pinpoint a specific answer. It's still an emerging field with guidelines changing every now and then.
Thank you very much, Dr. Ahmed. I think we close our session now. Thank you very much for the attendance. For the CME, as many of you are asking, so you will receive an email from the organizer with a survey. Once you fill a survey, you will receive an explanation how to apply through TAM portal of Abu Dhabi government for the CME. Okay, as you can see in the screen in front of you. So thank you very much. And this session is closed. Bye.